mock up a job that we may attend any day of the week. So on arrival, the first thing we need to do is make sure that we don't make anything worse. So Roger's taking over control of the head, just in case that Karen may have some sort of spinal injuries. So whilst all this is going on, they're assessing Karen's level of consciousness, and they're going through different bits and pieces where they're checking the head and they're checking the pupils. And they're also making sure that they keep communicating with Karen and seeing how she is and making sure she feels at ease. Because it's quite a scary environment. You're having the worst day of your life when big red helicopter lands. And that's normally associated with things not being particularly good as well. So we need to make sure we keep communicating with the patients.
Yeah, that's kind of hungry, isn't it?
So they're now happy with the head. They've got the head stabilised for the moment using a collar, a stiff neck collar. So they're now going to start the second form of examination. So they're going to check Karen from head to toe to see what other injuries she may have. So they start at the chest, so they're looking for breathing. Karen loves that bit.
So does Roderick.
Okay, so Roger's felt for the chest, he's looking for any obvious broken bones, he's also going to listen to the chest. So we're actually we're listening to make sure both lungs are actually inflating the air that we can hear. Okay, he's moved on to the pelvis area. So they've moved on to the pelvis area. Karen's giving out a bit of a shriek, which is not uncommon. So that's quite a dangerous injury for us. The fractured pelvis can lose 2 litres of blood very, very quickly into the open cavities around it. So we need to make sure we stabilise that area. So this is one of the new pieces of equipment that we've now introduced onto the air ambulance. It's called the pelvic binder. The idea of this binder on application is when it's on, it literally does exactly what it says. It binds everything in place. So the girdle itself will hold the girdle in place and stop anything from moving. The problem we've got with a fractured pelvis is when things start moving, you can shear some quite big vessels that go through the pelvis, pass through the pelvis. And there's also some vital nerves that pass through to the legs. So the application is a 2-person application. They put it in place, and then when it's in place, they lock it down. Okay, so they're happy the pelvis is stable, so they're going to move on with the examination. Okay, so on examination, they've actually noticed some deformity in the femur. And the femur is actually the long bone at the top of your leg. And again, we can lose 2 pints of blood. So if you think we've got a potential of a fractured pelvis, and now we've got a potential of a fractured femur as well, we're down to 4 litres of blood. So at this stage, whilst they're managing the fractures, Gareth is continuously talking to Karen and assessing her level of consciousness. Because one of the main fears now is that Karen may go into shock at some stage. So again, the splint is a new piece of equipment we've introduced onto the aircraft. And you'll notice it's quite a small piece of kit, and everything that we use, we've got to be very mindful of what we can actually fit on the aircraft, and also the weight. It was pretty much adapted from mountain climbers who got themselves into trouble on the mountains and adapted their ski poles to immobilised limbs. I can assure you it's an awful lot more expensive than a ski pole. So the idea is when this piece of equipment is in place, we'll then apply traction to the bones. When we apply traction, it will realign the bones and again stabilise them. As you see, there's constant communication going on. So there's communication between the crew, and there's also communication between the patient and the crew members themselves. It's lovely to be able to do this in a nice controlled environment. You can imagine doing this at -20 on the top of a mountain somewhere, where they're all tangled up in logs and bricks and rocks and all sorts of debris. It makes life very interesting. Okay, we've noticed now that Karen's actually taken a turn for the worse, so where we were worried about blood loss, it's actually kicking in now. So Karen's level of consciousness has dropped, and she's actually struggling to breathe at the moment. So previously we would have had 2 adjuncts that we could have used to support her breathing. One of them is a bicarb mat, and one of them is an ET tube, and that's tube that we actually pass down the throat, which is an excellent and still a gold standard for everything we do, but it's quite difficult sometimes for some of the environments we're in. Okay, so if we start off, they're just supporting the airway, supporting some breathing for Karen. Because she's bleeding, she's actually struggling now with the vascular access, which means that her blood pressure is dropping. We have needles that we use, and we would insert needles, but in this type of situation, especially with cold patients, it can be quite difficult to get a needle in. So another piece of equipment we've now introduced is something called the Easy IO gun. And the Easy IO gun is basically a drill where we drill a needle into the bone of the patient. It sounds extremely brutal, but it's very, very effective. And believe it or not, it's actually less painful than having a needle inserted. Because the only pain threshold is as it passes through the skin. Since we go into the bone, there's no nerve beds in the bone, so it no longer hurts. Okay, so Roger's now decided we can't manage the airway just using a bag valve mask, and we'll hope the airways we use. So we go on to another piece of equipment that we've introduced on the aircraft, and that's called an iGel laryngeal mask. Now in the air, it's quite difficult because of the confined space to actually insert an ET tube. So what we would normally do is ask the pilot to land in the nearest field, and then we would set ourselves up and do an intubation of the patient, where we would pass the tube down their throat. Whilst this is going on, potentially it can be quite dangerous for that patient because we've already lost the airway and we've got to find somewhere to land and set it all up. So what we need is for something to go in the middle of that time, and we've introduced this piece of kit which is called the iGel. So I'm just checking what piece of kit they're using, so I'm just looking at Roger's bum. Okay, so as you can see, the iGel is very, very fast and efficient, and we can do this with pretty much any position in the aircraft. And as soon as it's in place, we've got an airway. Most patients, we can actually manage them on the iGel all the way to hospital. But if nothing else, it gives us an opportunity to land safely, because the pressure is now off the pilot to say, we're in trouble, we need to get down quick. He can find a better place to stop, or we can continue on if the paramedic's happy with what we've got.